The following podcast is part of a certified educational activity titled Clotting the Gaps in VWD Care, Elevating Diagnostic Awareness and Treatment Planning with Modern Therapeutic Approaches. Access the entire activity and complete the post-test at peerview.com/GXU860. Downloadable slides and practice aids are also available.
Hi, this is Dr. Maisa Jambain from Tulane University in New Orleans. Welcome to this microlearning activity, Clotting the Gaps in VWD Care. The goals of this program will be to increase your awareness of some barriers to optimal VWD care, from underdiagnosis to management challenges, to augment your ability to utilize validated tools for the diagnosis and classification of VWD, sharpen your skills for developing individualized treatment plans using modern therapeutics, including with VWF concentrates, and enhance your ability to address practical aspects of VWD care, such as patient education, care coordination, and safety considerations in collaboration with other healthcare providers. We'll achieve these goals through a series of concise educational modules that will explore topics such as challenges and barriers to diagnosis and treatment of VWD, guidelines and tools for establishing a VWD diagnosis, the role of modern therapeutics such as DDAVP, plasma-derived, and recombinant VWF concentrates, and team-based strategies for enhancing patient outcomes with modern therapeutics. This microlearning activity offers you the opportunity to learn based on your own preferences and interests. Let's get started.
Find out how much you know about optimal management of von Willebrand disease through a simple 3-step process in this self-assessment activity comprising 5 question modules. First, answer the baseline question to evaluate your knowledge and skills. Next, review the supporting evidence shared by Dr. Maisa Jambain. Finally, answer the question again to demonstrate what you've learned. Each correct answer automatically counts toward post-test completion, which means that getting your CME credit is fast and easy.
You've just answered the question about barriers to the timely and accurate diagnosis of VWD. Now let's take a look at how we've arrived at this point. And we'll start with a historical outlook when back in 1924, Dr. Eric von Willebrand described an index case of a 5-year-old Finnish girl as the first case of VWD. Today, it's considered the most common inherited bleeding disorder found in up to 1% of the US population, with approximately 3.2 million people having VWD, so 1 in every 100, and occurring equally in men and women since it's an autosomal disease. VWF is a large protein that actually has different multimer sizes. The larger the multimer is, the better the VWF is going to bind to platelets and bridge them to the site of bleeding with collagen in the subendothelial matrix, which is really the highlight of the role of VWF in primary hemostasis. But also, in addition to that, VWF plays a role in secondary hemostasis by stabilizing factor VIII in the circulation. VWF is synthesized and stored in endothelial cells, and it's usually cleaved by ADAMTS13 protein, which regulates its secretion into the plasma and also regulates the accumulation of the high molecular weight multimers. VWD is classified into different types, whether we're dealing with quantitative or qualitative deficiency. Type 1, which accounts for the most common type of VWD. It's actually a partial quantitative VWF deficiency. Type 3 is the least actually frequent, with prevalence of 1 in a million, and it's virtually complete deficiency of VWF. And type 2 is a qualitative deficiency, and really depending on the activity or the function of the VWF that is affected, we have different subtypes of type 2, type 2A, type 2B, type 2M, and type 2N, with type 2A being a decreased VWF-dependent platelet adhesion because of the lack of selective high molecular weight multimers. Type 2B is a gain of function in VWF, leading to increased affinity for platelet GP1B. Type 2M is the opposite. It's a loss of function, leading to less or decreased VWF-dependent platelet adhesion, and without deficiency, without selective deficiency in high molecular weight multimers. In type 2N, it's where there is markedly decreased binding affinity to factor VIII, and in this type also there's no deficiency in high molecular weight multimers. This is a slide that shows actually the different results of testing with the different types, type 1 and type 3 being quantitative. So you see like a decrease markedly in type 3. In type 1, the decrease is going to be the same in the antigen and activity as well as in factor VIII. And then the multimer distribution is going to be normal but decreased all over. And type 3 will have absent multimers and very low levels of antigen of activity and factor VIII. And in type 1C, which is also rapid clearance, we will have the highlight will be the ratio of propeptide to antigen is going to be increased when we compare it to the other types of type 1. This is a slide, again, highlighting the different pathophysiology of the type 2, which is the qualitative deficiency of VW. So type 2A has absent high and intermediate weight multimer leading to decreased platelet binding. And so there will be like the high molecular weight will be lacking, and the ratio of activity to antigen will be also abnormal, less than 0.6, because there's marked decrease in activity compared to the antigen. In type 2B, where there is this gain of function, again, there will be abnormal multimer distribution and thrombocytopenia. In type 2N, it's because if there's no binding to factor VIII, they really manifest like hemophilia, with factor VIII being markedly decreased, and there is normal multimer distribution. In type 2M, where the decreased platelet binding due to loss of function mutation in the binding site and VWF is not associated with selective deficiency in high molecular weight multimers. So we will have normal multimer, but abnormal activity to antigen ratio. And if we look at like the challenges in diagnosis, the main challenge is that VWF levels really vary with different actually factors. One of them is age. And in this slide, you can see the impact of age actually on VWF levels with really high variability. Some levels that some patients that start with low levels and then increase with advancing age. But there are also other physiologic conditions that can temporarily increase the VWF levels, like pregnancy, hormonal therapy, oral contraceptives, inflammation, and stress. And also, in addition to that, there has been also more studies that looked at the effect of blood type, with the difference between O and non-O groups on the VWF. And it has been widely established that blood group O is associated with lower VWF levels, as shown on this slide. In addition to that, again, because of the other conditions that usually accompany the variabilities in the VWF levels, the challenge or the diagnosis of VWF becomes very challenging. And sometimes require testing different occasions. So especially for type 1, which is the partial quantitative deficiency. So in summary, VWD is challenging to diagnose, again, owing to the disease heterogeneity, and there's no single lab test that can determine the presence or absence of functional VWF, and pre- and post-analytical factors can result in falsely low VWF levels. On average, patients do experience between 1 and 2 year delay from initial bleeding symptoms to diagnosis of VWD, and inadequate use of diagnostic and assessment tools lead to under or misdiagnosis of VWD. An increased understanding and awareness of VWD, along with the use of validated tools and guideline recommendations, can help reduce these delays in diagnosis. So let's explore these guidelines, tools, and techniques. And we'll start with a case discussion of the 15-year-old female that presented with severe bleeding after a dental procedure, reporting a history of easy bruising with heavy menstrual bleeding that has improved on combined oral contraceptive. She was diagnosed with iron deficiency anemia, and she did not report any any relevant family history. So what symptoms should raise suspicion of a bleeding disorder whenever we deal with these patients? And what testing should be done to establish a diagnosis of VWD or rule out differential diagnosis? When we deal with these patients, of course, there's usually a series or a list of differential diagnoses that we look at, like in addition to VWD, what else could it be? Can it be a platelet function disorder, some other coagulation or clotting factor deficiencies, or some fibrinolytic defects? We have to keep this in mind. Of course, we usually recommend to start with bleeding assessment tools. And as you can see here, there were several bleeding assessment tools that were developed between 2008 and 2013. They really vary between the time, the administration time from 10 minutes to 20 minutes. But it is recommended usually for patients with low probability of VWD. Guidelines recommend actually bleeding assessment tools as initial screening tests to determine who needs specific blood testing. And for patients with intermediate high probability, like family history of VWD, guidelines do not recommend usually bleeding assessment tools to determine the need of laboratory testing, and rather immediately move to lab testing. On this slide, you can see the panel or the pool of tests that the lab tests that are available to evaluate or diagnose VWD, starting with antigen for quantification of the VWF protein. But there are different also activity testing that are available there, with the rhizocetin cofactor assay being the most widely available. But unfortunately, it has a lot of inter and intra lab variabilities. There are more specific testing or epitope-specific testing that have been developed, including VWF GP1BM, GP1BR, the collagen binding assay, propeptide, which we use mainly for the type 1C or rapid clearance, and some acquired also VWF, disease. And then the low dose rhizocetin-induced platelet aggregation that we mainly use for type 2B, the factor 8 clotting assay that should be part of every panel for rule out VWF, while the VWF factor 8 binding assay is mainly used to diagnose type 2N. In addition to that, genetic testing is becoming widely available and was pushed up front by the most recent guidelines released in 2021 by ASH, ISTH, NBTF, and WFH. As you can see that they did recommend actually the binding assay for factor 8 or targeted genetic testing to rule out type 2N, as well as for type 2A and type 2B. They recommended actually targeted genetic testing over the low-dose RIPA for patients suspected with these subtypes. This is a slide again showing the diagnostic algorithm, and I want to highlight mainly here the difference between severe type 1 VWD and the type 3 VWD. Again, type 3 where we don't have it's complete, virtually complete deficiency of VWF, so the levels are all very decreased, while in type 1 it's partial deficiency, but it can be sometimes severe, and the difference between them is the propeptide still being higher in type 1 compared to type 3, where it's more of a really initial deficiency and not clearance issue. It takes time to diagnose VWD, as I mentioned, because of the variability between VWF levels, the fact that it might be affected by different factors. And on this slide, extracted from a publication by Sidonio in 2017, you can see that there are also different members or different physicians that are involved in diagnosing VWD. So adding to the time, the team, the heterogeneous team that might be taking care of actually patients with VWD. And you can see there are hospitalists, ER physicians, gynecologists, primary care, hematologists, pediatrician, surgeons, especially ENT, that take care or might be the first physicians actually identifying patients with VWD, whether they're females or males. And only 21% of patients were really diagnosed by hematologists. This is raising again the need to broaden our awareness and our actually training of these different physicians to accurately identify patients and diagnose them. So take home points based on this case. We need to use bleeding assessment tools more frequently. We need to be aware that there are more specific lab tests for VWD that can be used upfront at initial diagnosis. We will need more than 2 sets of subnormal results, ideally 3 months apart, to confirm the diagnosis because of the variability and the levels. And again, we need to keep in mind that there are patients that actually might have initially abnormal levels that then normalize with age, and knowing how to approach these patients is crucial. So diagnostic challenges in VWD have translated into management challenges and inadequate treatment of bleeding episodes. Let's dive deeper into these unmet needs. As you can see here, there were a lot of advances that happened in the management of VWD, from the first prescription in 1926 up to the FDA approval of the first recombinant VWF concentrate in 2015. In between, treatment included plasma fractions, pools of cryoprecipitate. It wasn't actually, VWF was not cultured from human endothelial cells till 1973, but then the gene was not sequenced till 1985, and then ADAMTS13 was identified in 1996. In between, pasteurized factor VIII VWF concentrates became available in Germany in 1981. And if we look at the impact of VWD diagnosis on bleeding episodes, again published by Sidonio in Hemophilia in 2017, we can see, and this is based on analysis of medical insurance claims data, you can see that the frequency of bleeds before and after VWD diagnosis decreased, but it wasn't really like markedly decreased as we would have hoped. And that suggests, again, lack of guidance and aggressive, probably, treatment approaches. And this is both in female and male patients. If we look more at the type of these bleeding episodes, we can see that the total bleeds are probably the major, like in general, did not decrease. But I want you to specifically actually look here at probably the heavy menstrual bleeding, which has decreased, but not very much. It probably decreased like the more apart probably from diagnosis, because you would assume that these patients did seek more medical attention or probably tried different modalities in the meanwhile. But also what I want you to look at is the GI bleeds. Unfortunately, as shown here, they did not decrease between prior to diagnosis and after diagnosis. And that leads us to a little bit more discussion about GI bleeds and the challenges actually of GI bleeds and VWD. And as shown in this publication from 2022, trying to understand better the GI bleeding in VWD, where it's not probably just a bleed secondary to the deficiency in VW, but also VW here contributes somehow to the pathophysiology or the development of the lesions leading to the GI bleed, which are linked to the loss and high molecular weight multimers. As shown here, a GI bleed affects 38% of patients with VWD, most frequently type 3, but also type 2A and type 2B, again, with these patients with lack of high molecular weight multimers, which are due to the development of these angiodysplasia. And knowing that the diagnosis of angiodysplasia related GI bleeding is challenging because they tend to occur more in the small intestine, which is not visualized by conventional endoscopy, and requires usually multiple GI investigations and sometimes more video capsule endoscopy. So really leading to underdiagnosis of these conditions and probably under management of these conditions. The treatment of the GI bleed and VWD involves treating the bleed as well as the underlying disorder to prevent recurrent GI bleeds. If we go back to the publication by Sidonia from 2017, looking also at the specialists that continued taking care or managing the bleeding episodes of patients with VWD, even after diagnosis, you can see that you would imagine that these patients should be now taken care by hematologists only, but you can still see that there is still like a big team taking care of these patients. And unfortunately, hospitalists and ER physicians still account for the majority of the management or the physicians managing the bleeding episodes in these patients, again highlighting the lacking aggressive management and probably channeling of these patients to the specialists who are hematologists. So in summary, to improve the management of VWD, we need to address these challenges and unmet needs, from the diagnostic delays, which result in more bleeding episodes, high ER visits, and apparently persist even after diagnosis, suggesting inadequate management of VWD. There is lack of standardization approaches, clear guidance on when and how to treat VWD, due to the heterogeneity of the disease, but that leads to frustration from providers and patients. Of course, also there are challenges related to the need for IV infusions with available therapies, including sometimes resistance among patients to adopt these treatments. And it's really difficult to measure success of therapy due to the absence of long-term impacts of bleeding in patients with VWD, except for the iron deficiency anemia, which we should start using more aggressively as a surrogate of severe bleeding in our patients and guide our therapy. VWD in women is often more clinically severe due to menorrhagia and poses unique challenges, especially during pregnancy. Several treatment options are approved for the management of bleeding episodes in VWD. Let's take a look at some of the evidence supporting these treatment modalities. And we'll start with desmopressin. How desmopressin works? It does work by releasing preformed stored VWF and also factor VIII from the endothelium. It also works by enhancing the interaction between platelets and VWF and binding to the VWF receptors on platelets. It is effective in the majority of patients with VWD, but not in all of them. So patients usually need to be challenged before prescribing desmopressin to them. In addition to that, it's associated with adverse effects, especially in terms of fluid retention and making the prescription of desmopressin in some clinical contexts challenging, where fluid resuscitation is needed. And of course, in addition to that, there is tachyphylaxis that we should pay attention to in terms of we cannot redose with desmopressin if needed. In addition to that, the VWF concentrates are available for the management of VWD. Patients with VWD usually have both low VWF and factor VIII, really depending on the type. Patients with type 3 have much lower factor VIII baseline. Patients with type 2 might have, type 2N also have very low factor VIII baseline. And the other subtypes of type 2 and type 1 might have variable baseline of factor VIII. There are plasma-derived products and also that contain both VWF and factor VIII, and recombinant product which contains only VWF, and we're going to talk a lot about it more later. To reduce the potential thrombogenicity, we have to keep in mind that the levels of factor VIII should remain below 250%, and for the activity, for VWF activity, should remain less than 200%, keeping in mind that the target for during the postoperative period of factor VIII concentration is usually between 50 and 150. So there is a sweet spot that we want to stay within. Do not overshoot above 250. But depending on, of course, some surgical procedures, a level closer to 100 might be needed. This is a slide showing the different plasma-derived and recombinant concentrates available for VWF, and you can see that they, especially for the plasma-derived, they vary in terms of the VWF to factor VIII ratio, with Willate having closer to 1 ratio, while Humate provides more VWF protein than factor VIII. then there is the von Venti or the recombinant VWF, which does not have any plasma component in it. It does not have factor VIII. And because it does not have any plasma component in it, it does not have ADAMTS13. So there will be like higher content of ultra large multimers when we compare it to the plasma-derived product. This slide presented at ISTH last year in 2023 showed that the long-term efficacy of on-demand prophy and surgical management with HUME-HP. And you can see, and the efficacy in terms of hemostatic control was rated excellent and good between 93.7% and 98.1%. With less than 0.7% not having any assessment of their hemostatic control. As far as long-term safety profile of HUME-HP, again, you can see the high exposure data from in terms of like units, as well as dose exposures. There were 1,296 adverse reactions that were actually identified in the database from June 1982 to June 2022, with 58 cases of thromboembolism, 205 cases of hypersensitivity, 122 cases of inhibitor development, and no cases of viral transmission, speaking for the efficacy of pasteurization in viral inactivation. The recombinant VWF concentrate is there's only one approved recombinant VWF concentrate for the treatment of VWD, and it's von Venti. It is FDA approved since 2015. Again, it does not have any plasma components, so there's no factor VIII. It's only providing recombinant VWF, and it has high content of ultra-large multimers because it does not have any ADAMTS13 on board. The hemostatic efficacy and safety and PK data from clinical trial and some real-world data too speaks for 192 bleeding episodes that were treated for recombinant von Willebrand factor with 100% reported successful treatment, which was rated excellent in 97.5% of minor bleeds and 96.7% of moderate bleeds. And the median number of infusions was 2 with a range of 1 to 3 that was required to control major bleeds. Other therapies are used in the management of VWD, whether solo or adjunctive to the previously reported therapies. Antifibrinolytics who are used actually to prevent the breakdown of blood clots once they have started to form. So they support the body's natural clotting mechanism. They can be used alone in some cases, or as I said, adjunctive to the previously cited therapies. We mainly use them for mild mucosal bleeding and heavy menstrual bleeding, and we have 2 available in the US, tranexamic acid and aminocaproic acid. Hormonal therapy, whether it's estrogen or combined estrogen-progesterone preparations, can increase the VWF levels, and they have been used for reducing menorrhagia severity in women with VWD. In addition to that, there are ongoing actually studies that are looking at the efficacy and safety of von Venti in patients between the age of 12 and 18-year-old with severe VWD. Emicizumab, which is a factor VIII mimetic, is being assessed in patients over the age of 2-year-old and with severe VWD type 3. There are also some molecules like the antiprotein S monoclonal antibody that is being assessed in patients between 18 and 60 years old with symptomatic VWD in a phase 1 trial, and the BT200, which is an anti-VWF aptamer that shields the VWF from platelets, that is being assessed with in patients with type 2B and some patients with type 3 in phase 1 study. Now that we have a better understanding of the treatment options, let's explore some strategies and guidelines for improving outcomes of patients with VWD. And we'll start with a case of a 28-year-old male diagnosed with severe VWD type 1, who was not found to be a good responder to the DAVP. He has a planned dental procedure for which he needs prophylaxis. So what are our goals of therapy, and which treatment option will likely provide the best protection against bleeds during this type of procedure? And what would be the dosing, administration, and safety considerations that we have to look at? Again, the treatment strategy should really vary depending on the type of the disease. With type 1, we can offer desmopressin, again, after, of course, determining if the patient is responder to desmopressin or not. But for major surgery, VWF replacement may be preferable just because we will need to redose, and with desmopressin, we cannot redose. In type 3, the only available treatment is VWF concentrates, whether they're plasma or recombinant. But in recombinant, we will have to provide upfront recombinant factor 8, because again, these patients will have undetectable baseline factor 8 levels. And in type 2, depending on the subtype, in type 2A and type 2M, we can offer desmopressin after challenging patients. In type 2B, desmopressin is contraindicated because that will precipitate thrombocytopenia. So VWF concentrates are really universally probably used regardless of the type or subtype of VW disease. And in 2021, again, ASH, in collaboration with ISTH and BDF and WFH, released guidelines for unique bleeding situations, as you can see here, highlighting the need to determine a target von Willebrand activity level of 50%, along with antifibrinolytic for minor surgery that should be extended for at least 3 days or even more in major surgeries. And they did specifically talk about the use of hormonal therapy and or antifibrinolytic and heavy menstrual bleeding, and neuraxial anesthesia during pregnancy or in peripartum period. The target VWF activity can be safely between 50 and 150%. So in summary, the goals of VWD treatment is increasing VWF as well, and that can be done by desmopressin, which will lead to releasing the endogenous von Willebrand stored in endothelial cells, or by replacing with factor concentrates, whether it's plasma-derived or recombinant. And that also, in addition to that, we have to keep in mind that in some types 2 and in type 3, we will have to also raise factor 8 because the baseline factor 8 levels might be very low to ensure hemostatic control. And in addition to that, we can focus on stabilizing the clot stability using antifibrinolytics like tranexamic acid and aminocaproic acid. But really, it's important to involve the patients in a shared decision-making model, because if the patient is not really believing in the importance of managing their bleeding episodes and preventing bleeding in the future, they will not. That will lead to lower adherence and compliance. And as you can see here, this is a proposed multi-step approach to shared decision-making, starting with seeking the patient's participation, to really helping patients explore and compare treatment options, and then assessing the patient's goals, values, and preferences in a way to reach a decision with the patient and evaluate the patient's decision, so that leading to better adherence. The take-home points from this collaborative VWD management is that treatment choices should consider patient and product specific considerations, especially thrombosis risk, in addition to the bleeding risk. And based on the guideline recommendations, prophylaxis with factor concentrate targeting 50% or 0.5 IU per milliliter, along with antifibrinolytic therapy, should be initiated in preparation for the procedure. Encouraging obtaining PK measurement to determine procedural plan is actually of high importance, because it does help us determine what dose is required and how frequently. Sometimes we have to account for extra consumption whenever we're dealing with surgeries. In summary, the final take-homes on the diagnosis and management of VWD will start with guidelines for VWD diagnosis. We need to incorporate bleeding assessment tools more in our assessment of patients with possible bleeding disorders. We need to start using more specific lab tests for VWD at initial diagnosis, as well as upfront, probably genetic testing and the diagnosis of some subtypes of VWD in order to shorten the delays in confirming diagnosis of VWD. And we need to know more about how to approach patients with VWF levels that are initially abnormal and then normalize with age. In terms of VWD management, prophylaxis and more aggressive indication or probably prescription of prophylaxis needs to be incorporated in our management of VWD patients. Desmopressin, again, can be offered to a wide variety of patients with VWD disease, but of course we need to start with a challenge test to determine whether they're responders or not. Patients undergoing major or minor surgery need to be advised by a hematologist to develop a perioperative plan around their surgery. Pregnant ladies also need to seek advice from their hematologist and incorporate really multi-specialty team approach upfront, including the obstetrician and the anesthesiologist, to really advise patients with VWD during labor, but also in the postpartum period. Patients with VWD and heavy menstrual bleeding need to be more aggressively approached in terms of offering hormonal therapy, antifibrinolytics, or even a tailored prophy to control their bleeding.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from CSL Behring. To access all materials for this activity, visit peerview.com/GXU860.